Um, Welcome to another episode of the Nuclear Medicine and Molecular Medicine podcast. And we've always said for the last 10 years the most important factor in nuclear medicine is the chemistry. And so we're very fortunate today to speak to someone who's been a pioneer in probably, I think, the most exciting chemistry that's been done in the last 10 years. And I think it's made a difference to not just nuclear medicine, but medicine in general. And will continue to for a long time to come. So this is, we're at the actually Alzheimer's International meeting in Washington. Alzheimer's Association International meeting. And this is Professor Klunk, who really developed PIB. And PIB's famous. It's so famous that everybody calls it PIB. and I'd like to ask you a bit about where he is and where this all began.
Well, Rob, let me start by pointing out that I co-developed PIB, and the real radiochemist is Chet Mathis.
Yes.
But I'm always happy to masquerade as a chemist because that actually is my closet avocation and training. So, go ahead.
Yeah. So perhaps we could start by telling us a little bit about where it all began, where the initial idea came about for PIB, and how it came about, and then how it spread.
Well, neither of us realized it at the time, but it's sort of interesting that on separate coasts, both Chet and I ventured into this around the same time in the late 80s. Chet in Berkeley was approached by some colleagues about radioiodinating Congo red to image amyloid, which he did and found out that it didn't get into brain and had lots of other things pulling at his time, and that's where that stopped. Over in Pittsburgh, I was interested also in using Congo red in an amyloid project, but it got started out actually as a therapeutic project by a mentor at that time who was interested in looking at this newly discovered protein called beta amyloid, and could we get Congo red derivatives that would bind to it in a way that would prevent aggregation, because he was also interested in anti-sickle cell agents for hemoglobin. So my thought was, well...
So Congo red at that time was used for?
It's a histologic dye for amyloidosis in general.
Right.
So my thought was that, well, that would be great to have an anti-aggregation therapeutic, but if we could only do the first two steps, and that's to get it to bind to A beta and get into brain, or vice versa, then we could tag it, with a variety of things and have an imaging agent.
Right.
So that was sort of, parallel track, knowing that until you could get it into the brain and bind to A beta, you wouldn't have a therapeutic anyway.
Yes.
So we sort of started on opposite coasts, both on Congo red, and I took a more medicinal chemistry approach and began varying the structure to increase the lipophilicity of Congo red derivatives, and did that for a few years. And then Chet moved to Pittsburgh, and we were introduced and began a collaboration, and that's where I think things really took a radiochemical rather than a medicinal chemical direction. And we worked for a number of years together, probably 5 or 6 on Congo red derivatives, trying to get them good enough. And it was always a struggle to get these relatively large, relatively both polar and at some points, and very lipophilic because of multiple benzene rings and conjugation, to get them to have the proper properties of getting into brain enough and getting them to clear enough. So it was after a few years of that we decided we should look beyond Congo red, and the next two obvious agents were thioflavin S and thioflavin T, which are very chemically different. Thioflavin S actually binds to the same site as Congo red, whereas thioflavin T is different, and it's chemically well defined. It's a small molecule. So we took the information we learned over those 8 years or so working on Congo red derivatives and applied them to the thioflavin T problem, and then very rapidly began to make progress getting things into brain to bind amyloid to clear. And I think it was maybe the 20-something, 26th compound, 23rd compound was PIB.
Persistence.
Yeah, after a few hundred Congo red derivatives, persistence paid off.
Right. So, how did you first get an image? How did that go about? What were the first sort of images?
Well, the first images were actually done in collaboration with a team in Uppsala and Karolinska in Sweden. So Bengt Langström at Uppsala University had long been interested in the work we were doing, was aware of it, and offered to collaborate for human studies, to facilitate human studies because of the microdosing concept in Sweden around 2000, I guess that was. Much like we have an exploratory IND here in the U.S. today that really facilitates this sort of tracer discovery. They were a decade ahead of us, I guess. And we began the toxicology studies to do the U.S. studies at the same time we began the collaboration with the Swedes. They were in a position to do a human study in 2002. It was more than a year after that that we were in a position to do one in the U.S. So the first studies were done in Uppsala, Sweden, by Bengt and Agneta Nordberg, who characterized and gathered the subjects for the study. And it was on actually Valentine's Day 2002 that the first study was done.
Right.
I always remember the date.
And then shortly after that, it started to be done elsewhere around the world, right?
Yeah, we were from the very beginning. Well, from the very beginning, we were sharing the technology because we were doing the study in Sweden. So we remained very eager to get this into other hands because that's what has to happen to any technology. It has to be evaluated by other people. They have to be able to touch and feel it in a sense, you know, and look through their own images and scale their own images and convince themselves whether it's any good or not. And we truly believed that it was from the early studies, and we're happy to share it. You know, we had a discussion earlier about stealing thunder, and you know, I mentioned that that's actually made the thunder,
right.
That dissemination of technology.
Well, it's proven to be a brilliant agent because it's really still the gold standard for amyloid imaging, isn't it? And there's been a lot of research done by commercial companies to expand this into fluorine-18 agents, hasn't there? But it's still the gold standard.
It has. It's sort of interesting that you know, one of the first agents has stood at least the test of time over a decade, more than that now. The fluorine tracers, of course, have the advantage of what the 109-minute half-life can give you, but I don't think anyone who can do both in a small population at a single site would say the fluorine agents have any scientific advantage. The advantage, of course, is you don't want to do studies at a single site. You want to do them at multiple sites, and many of these sites won't have cyclotrons.
Right.
So the only way to practically do those studies is with an F18 agent. And just like the group at Avid and initially AstraZeneca, now Piramal, we and GE Healthcare developed fluorine-18 agents, and you know, they've done quite a good job, even though they lack some of the sensitivity and signal to noise that Pittsburgh Compound B PIB does.
Right. So why has this changed medicine? Why being able to image amyloid? How's that changed medicine?
Well, I think it's changed at least Alzheimer's disease, the approach to that, because you know, I think it's really at this meeting, sitting back and hearing PIB mentioned here, PIB mentioned there, and you know, it's really sort of used in the same way that APOE4 has been used. You sort of need to define your cohort. We all know whether our cohorts are E4, 2, 3, or 4, and mixtures thereof. Now it's a little more difficult, of course, to get a PET scan than a genotype. But many of the studies presented here presented in the context of either continuous or dichotomous characterization of amyloid status. So of course, I think the ultimate usefulness of that is it's been a facilitating technology for prevention studies.
Right.
So if we want to say we want to get to the disease before the symptoms are present, when that disease has been essentially invisible, and get to it before perhaps the hippocampal changes, volume changes have occurred, the hypometabolism has occurred, that's only possible if you can see whether or not there's amyloid in the brain as we sit here today. So the major prevention trials are either have a major pillar is amyloid imaging, or the foundation itself, without which it couldn't be done. I would say the A4 study is the perfect example of that. In order to get into the study, you have to demonstrate that you're amyloid positive.
It could be argued that the failure of previous therapy studies is because imaging wasn't used in order to select the right patients at the right time.
Well, I think we've all been struck by the bapineuzumab and solanezumab E4 negative arms. So that's about half of the patients in both studies. And it's remarkably similar. I believe the numbers were 36 to 37% of those E4 negative subjects were amyloid negative.
Right.
So the chances of removing amyloid from an amyloid negative person are nil.
So it's crazy. With the cost of running a therapy trial is very high, any kind of clinical therapy. So you want to target the therapy at only the people that can benefit. So it's almost crazy that you would not design a trial now that we can image, without targeting it properly.
Well, I think we've seen that. I think that's benefited the Biogen aducanumab trial that I think addressed this a little more carefully, and approached their dosing a little more aggressively too, and have shown really striking reductions in the fluor beta peer signal in that small study. Let's hope those results aren't fleeting and they'll show up in the phase 3 trial as well.
Well, I think the other thing is that we seem to know that if the treatment comes too late, after the tau has started to spread, then it's not going to be effective. So that really leads us to the next arm in terms of the future. Is it really tau imaging and being specific around tau imaging to really do one sort of imaging to see whether people have got amyloid and another sort of imaging to see that they haven't got tau?
Right. I think it depends on the research study, the therapeutic trial, the mixtures of where amyloid imaging may or may not play a role, where tau imaging may or may not play a role. And I think we also have to be careful not to rush to the conclusion that because we're where we are with amyloid imaging, that when the first tau agent shows up, we're at an equal spot. I mentioned that the first PIB study was done February 14th, 2002. I think we're much closer to that point in time with our tau imaging than we are to July, whatever the date today is, 2015.
So how many compounds did you try for amyloid? There was hundreds, right?
Hundreds, yes.
We haven't got to that stage with in terms of effectiveness, and I think looking at the tau images, they're not as good in terms of specificity. We haven't proven their specificity yet.
Well, that's it. We don't know. What I think we'll find with tau imaging is like we found with amyloid imaging, that a neuropathological approach and an in vivo imaging approach are two very different things, and you will learn two sets of information from them, and it doesn't make one set of information wrong and one set of information right. The two inform each other. So I think there's been not only just the pathology informing the imaging, but I think the imaging has fed back on the pathology and maybe said things like, hey, maybe you should look here a little more carefully when you talk about the precuneus or the striatum in amyloid imaging. And I think tau imaging, in one of the plenaries this morning, the statement was made that the typical 9 slides for neuropathology for the CIRAD diagnosis of Alzheimer's disease assesses about 1/16,000th of the volume of the brain.
Right.
So the chances that you'll miss a few things are high. So I think in vivo tau imaging will inform pathology in ways that pathology alone could not, and vice versa. So yeah, there's still a lot to learn, but I think it still is valid to progress. I think tau has gotten to the point where it makes sense to progress in parallel of beginning to assess biological information while we're understanding the tracers themselves. The problem may come when we have to switch tracers midstream if one clearly stands out above the other, and that's not the one you're using. And you've gathered a lot of data, but we've seen those sorts of transitions for the more practical reasons in amyloid imaging from the carbon-11 based tracers to the F18 based tracers. So those transitions can be made.
Right, and we've done similar things with cardiac historically. I mean, we've changed traces quite a few times with cardiac, and they've all had different advantages and disadvantages. I guess what I'm trying to say is when we get something that's good enough for diagnosis, is it good enough for therapy? Should we keep on researching to improve amyloid imaging? Should we keep on researching to improve tau imaging and maybe other biochemicals, maybe other functions? Isn't that important that we keep on going?
Well, as a neuropharmacologist and a wannabe medicinal chemist, you want to keep doing the chemistry and you want to make it better and better and better and better. But there are others who aren't as enamored by chemistry for the sake of chemistry, and those people are often asked to pay for that process. And the question is, how long can you convince them that you need something better before they say, this is good enough for what we want to do? Now, sometimes it may not be, and you only learn that down the road. And then there'll be a call for better compounds. But right now, it's hard to convince anyone that we should be taking money that could be spent on tau or alpha-synuclein or TDP-43 imaging agent discovery and look for a 1%, 5% better A-beta tracer.
I guess the argument might be is historically tracers were used as a diagnostic tool.
Right.
We're not using them as a diagnostic tool. We're using them as a therapeutic tool. And therapeutic is about precision, it's about change over time. So perhaps that's a good argument to keep getting better.
I agree. I think that as you slice it finer, you come to the limits of the current tracers. And if you go beyond those limits, you could slice it even finer. I will say, though, that I think in the therapeutic trials, we're hoping that the anti-amyloid agents, at least, have a readout that's big enough for all of these tracers to see, to be clinically significant. We probably can't be just sort of dusting the top off the amyloid in the brain. I think we need to be carving deep into that pile.
Right. I guess in terms of therapy trials, though, they're expensive. If you have to wait 3 years for a therapy to be proven effective when you could wait 3 months, then, or 6 months, in terms of using your imaging to guide it, then that's going to making that tracer a bit better cost effective.
If you could do that, yeah.
Yeah.
You could do that.
Well, thank you very much for your time. I know you're very busy, and I really appreciate what you've done for us and for medicine and for nuclear medicine and for the future, because I think we've got to remember what we're here for, and we're dealing with the most costly and painful disease, I think, in terms of large numbers of people in the world.
Yeah. Well, that's very kind of you to say. Thank you.
Right. Thank you. How was that?